Good morning. This is a long topic in Schwartz, but I condensed it into just less than 20 slides. So we will just tackle on the basic um, gists on thoracic aneurysm and aortic dissection. So the aorta consists of major segments, the proximal and the distal aorta, whose anatomic characteristics affect both the clinical manifestations of disease in these sects and the selection of treatment strategies for such disease. The proximal aortic segment includes the ascending aorta and the transverse aortic arch. The ascending aorta begins at the aortic valve and ends at the origin of the innominate artery. The first portion of the ascending aorta is the aortic root, which includes the aortic valve annulus and the three sinuses of Valsalva. The coronary arteries originate from two of these sinuses. The aortic root joins the tubular portion of the ascending aorta at the sinotubular ridge. The transverse aortic arch is the area from which the brachiocephalic branches arise. So here, the distal aortic segment includes the descending thoracic aorta and the abdominal aorta. The descending thoracic aorta begins distal to the origin of the left subclavian artery and extends to the diaphragmatic hiatus where it joins the abdominal aorta. The descending thoracic aorta gives rise to multiple bronchial and esophageal branches as well as to the segmental intercostal arteries which provide circulation to the spinal cord. This chapter focuses mainly on the thoracic aorta because the volume of blood that flows through this area at high pressure is far greater than that found in any other vascular structure. So any condition that disrupts the integrity of the thoracic aorta like aneurysm or dissection can have catastrophic consequences. Aortic aneurysm in general is defined as a permanent localized dilatation of the aorta to a diameter that is at least 50% greater than is normal at the anatomic level. The annual incidence is 5.9 per 100,000 persons, and causes of which are mostly degenerative disease, aortic dissection, aortitis, infection, and trauma. In most extreme cases, the entire aorta is aneurysmal, and this condition is often called mega aorta. Aortic aneurysms can either be true or false aneurysm. True aneurysm can take two forms, fusiform and saccular. The fusiform aneurysm is more common and is characterized by symmetric dilatations of the aorta, while the saccular aneurysms, they are localized outpouchings of the aorta. False aneurysms or pseudoaneurysms are leaks in the aortic wall that are contained by the outer layer of the aorta and or periaortic tissue. These are usually caused by disruption of the aortic wall and lead blood to collect in the pouches of fibrotic tissue. Aneurysms of the thoracic aorta consistently increase in size and eventually progress to cause serious complications. Elective resection with graft replacement is indicated in asymptomatic patients with an aortic diameter of at least twice the normal. So that The cutoff is usually 5 to 6 centimeters in most thoracic segments. Emergency operation is performed for any patient in whom a ruptured aneurysm is suspected. The causes of thoracic aneurysm are diverse and are listed in the table that you can see here. So there is degeneration of the medial segment, dissection, um, heredity also plays a role, infection, trauma, and post-stenotic dilatation are also causes. But whatever the pathologic process is, they share the final common pathway of progressive aortic expansion and eventual rupture. So for thoracic aortic aneurysms, they have average expansion rates. For the ascending aorta, it is estimated at 0.07 centimeters per year, while the descending thoracic aorta is around 0.19 centimeters per year. The aortic diameter is a strong predictor of rupture, dissection, and mortality. Annual rates of complications for thoracic aortic aneurysms more than 6 centimeters is around 3.6% for rupture, 3.7% for aortic dissection, and death in as high as 10.8% of patients. We have the so-called hinge point diameters, mga cut-off sizes, at which the incidence of complications significantly increase. So for the ascending aorta, the hinge point diameter is 6 centimeters, while for the descending thoracic aorta, it's 7 centimeters. Initially, aneurysmal expansion and impingement on adjacent structures causes mild chronic pain. The most common symptom in patients with ascending aortic aneurysms is anterior chest discomfort. Aneurysms of the ascending aorta and transverse aortic arch can cause symptoms related to compression of the superior vena cava, the pulmonary artery, the airway, or the sternum. Expansion of the distal aortic arch can stretch the recurrent laryngeal nerve, which results in left vocal cord paralysis and eventual hoarseness. Descending thoracic and thoracoabdominal aneurysms frequently cause back pain localized between the scapulae. When the aneurysm is largest in the region of the aortic hiatus, it may cause middle back and epigastric pain. Descending thoracic aortic aneurysms may cause varying degrees of airway obstruction, manifesting as cough, wheezing, stridor, or pneumonitis. Pulmonary or airway erosion presents as hemoptysis. Diagnostic evaluation requires imaging studies, which also provide critical information that guides the selection of treatment options. Chest X-ray may produce a convex shadow to the right of cardiac silhouette, but they may also appear normal in other patients. So this is not a very specific diagnostic tool. 2D echo and abdominal ultrasound can help us. Um, Ascending aortic aneurysms are commonly discovered during 2D echo. Both transesophageal and transthoracic echocardiography. They both provide excellent visualization of the ascending aorta and even including the aortic root. Ultrasound may be done during initial evaluation of suspected infrarenal abdominal aortic aneurysm. CT scan is particularly useful in determining the absolute diameter of the aorta, especially in the presence of a laminated clot and it also detects aortic calcification. This actually is the most common and the most useful imaging modality. We also have MR angiography. It's MRI, but it's angiography, um, mostly for the vessels. MR angiography produces aortic images comparable to those produced by contrast-enhanced CT. But the good thing here is it does not produce ionizing radiation. What is quite a downside on MR angiography is that it's MRI, so you have to stay inside the room for like an hour or so, and it's not for those who are claustrophobic. Another thing is if you have patients who are in need of immediate surgical management or emergency patients, so then we cannot do MR angiography since it takes time. Also, the cost effectiveness of MR angiography is not that good. CT scan is way cheaper than MR angiography. So we have another diagnostic evaluation, the invasive aortography and cardiac catheterization. So this is the percutaneous one. This was the gold standard, but this is now replaced by cross-sectional imaging. Cross-sectional imaging meaning the CT scan, CT angio, and the MR angiography. So cardiac catheterization is now limited to those undergoing endovascular therapies or when other types of studies are contraindicated or have not provided satisfactory results. So treatment is mainly um, open or endovascular repair. So when do we do endovascular repair? This is strongly considered for patients with descending thoracic aneurysm at an aortic diameter of 5.5 centimeters. But you have to follow the following criteria. The proximal, that means the brachiocephalic, and the distal or the celiac axis, so this is for the ascending. Neck diameters should fall within a range that will allow sealing. The proximal, that's proximal guys, and distal landing zones are at least 20 millimeters long, and the femoral and iliac arteries have to be wide enough to accommodate sheaths used to deploy stent grafts. So patients who benefit most from an endovascular approach are those who are of advanced age or those who have significant comorbidities. The endovascular repair in patients with heritable syndromic conditions, because like um, aneurysm is common in say Marfan syndrome, so those with those kinds of syndromes have produced poor results, so most likely those patients have to undergo an open procedure. So that's for the this one is for the descending aortic. So for the descending, this one pala is the descending. So for the descending or the thoracoabdominal aortic aneurysm repairs, again, they are also dictated by the overall extent of the aortic involvement. So surgical repair for these kinds of aneurysms is categorized by the extent of aortic replacement according to the Crawford classification scheme. So first extent, so most of the descending thoracic aorta from the subclavian artery up here down to the suprarenal abdominal aorta. So resect and replace. Second extent number 2, left subclavian up to the infrarenal abdominal aorta. Sometimes they reach the bifurcation of the iliacs. Okay, so extent 3, third segment from the lower descending thoracic aorta, so this is below the sixth rib and into the abdomen, can reach again the infrarenal, the bifurcation. And the last one is Fourth, extent number 4, they begin at the diaphragmatic hiatus and often involve the entire abdominal aorta. So that's how you replace um, aneurysms. Okay, so now let's proceed to aortic dissection. So, the aortic dissection is the most common catastrophic event involving the aorta. This is a progressive separation of the aortic wall layers that usually occurs after a tear forms in the intima and inner media. As the separation of the layers of the media propagates, two channels are typically formed. We have the true lumen and the false lumen. The true lumen is the original lumen, so this is the original lumen, remains lined by the intima, while the false lumen is the one here. This is the newly formed channel within the layers of the media. Yan. There, so this is the dissection. Eventually, magka-hematoma kay the blood clot stays here. And sometimes there is an aortic ulcer. Parang mag-open na siya ba? Okay. Additional tears in the dissecting membrane that allow communication between the two channels are called re-entry sites. So one comes in, the blood enters in one direction and there is another re-entry site in another site. Although the separation of layers primarily progresses distally along the length of the aorta, it can also proceed in a proximal direction. This process often is referred to as proximal extension or retrograde dissection. So what are the anatomic consequences of dissection? Number 1, the outer wall of the false lumen is extremely thin, inflamed, and fragile, prone to expansion or even rupture. So that one is fatal. Number 2, the expanding false lumen can compress the true lumen and cause malperfusion syndrome by interfering with blood flow. So the other parts of the body are not perfused with enough blood anymore kay na-compress naman ang true lumen. And number 3, when separation occurs at the aortic root, the aortic valve commissures can become unhinged, which results in acute valvular regurgitation. The classification of aortic dissection is done based on their anatomic location and the extent to guide the surgeons on the proper treatment. The most commonly used classifications are the DeBakey and the Stanford classification systems. The main drawback of the Stanford is that it does not distinguish between patients with isolated ascending aortic dissection and patients with dissection involving the entire aorta. So, start with Stanford A. Stanford A is all dissections involving the ascending aorta regardless of the site of origin. So this is Stanford A. This one is also Stanford A, even if involved ang descending aorta, because involved man ang ascending. Stanford B is all dissections not involving the ascending aorta. So tanang descending, Stanford B na automatic. The Bakey, on the other hand, we have the Bakey 1, the one on your right. This originates in the ascending aorta, propagates at least to the aortic arch, and often beyond it distally. So, can start sa ascending pababa. Okay? The Bakey 2, the one here on your left, originates in and is confined only to the ascending aorta. So, easiest to remember is the DeBakey 2. The DeBakey 3 is descending aorta ang origin. So, ang ascending, it's not involved. Descending aorta, pababa. So extends distally down the aorta or rarely retrograde into the aortic arch and ascending aorta. But mostly the Bakey is just koan. The Bakey 3 descending pababa. In light of the importance of acuity, Borst and Associates have proposed a uh, sorry. Before that, I have to discuss acute dissection first. So, there is a term called acute dissection within the first 14 days after the initial tear, and chronic dissection after 14 days. But then again, si Borst and his colleagues have proposed a third phase. The term is subacute dissection. So the subacute dissection is the transition between the acute and the chronic phase. According to him, the period encompasses days 15 through 60 after the initial tear. So, if you come to think of it, this is past the traditional 14-day acute phase, right? But patients with subacute dissection continue to have extremely fragile aortic tissue, which may complicate the operative treatment and increase the risks associated with surgery. That's why there is another third term. But usually it's just chronic dissection and acute dissection. So the onset of dissection is often associated with severe chest or back pain, classically described as tearing. There is also a discrepancy between the extremities in pulse, BP, or both because of changes in the flow in the true and the false lumens. So CT scan, MR angiography, or 2D echo should be done once dissection is considered, with contrast-enhanced CT scan providing definitive diagnosis at the fastest possible time. Sensitivity is 98%, while the specificity is 87%. So how do we manage aortic dissection? So this is the algorithm. This is in your book, Schwartz. How to manage acute aortic dissection. So first thing to remember here is to control the blood pressure. It should not shoot up so as to minimize turbulence and the flow of blood from the true to the false lumen. So if the patient is stable, we may then perform diagnostic imaging. So typically CT scan or CT angiography because it's the fastest and it can tell us the diameter of the dissection and can tell us also if it is if where the true lumen is, where the false lumen is. It's very sensitive. So yes, if dissection is noted, then we determine the classification. Is it Stanford A? Is it Stanford B? Or what? So Stanford A dissections require emergency operation. So if the dissection has malperfusion or remember malperfusion pag the false lumen is very big to the point na the true lumen is compressed already. So that's malperfusion. So if there is already malperfusion or if there is rupture, of course, emergency endovascular or open intervention is done. So the emergency endovascular, we can put a stent or balloon dilatation for that. But usually here, we do the open surgery. If not operable, the patient is transferred to the ICU for BP control and anti-impulse therapy. So BP control is very important in aortic dissection. So on the other side of the algorithm, we have hemodynamically unstable patients. So these patients, you have to go immediately to the operating room. We do intubation. We perform at the very least a transesophageal echocardiography. If the ascending aortic dissection is the Bakey 1 or the Bakey 2 or Stanford A, then do the emergency surgery. If no, then we can um, delay the surgery at a later time and then monitor the patient first. Do a diagnostic workup. So that's it. We won't delve deeper in the surgical aspect. So kay fellowship level na siya yun. So just review the slides. It's just 20 slides, 19 slides, and then we will have the post test. Okay, so that ends aneurysm and dissection.